And Marc Myer is our speaker today. He's addiction medicine certified and also has an MBA. And he and I worked together for quite a number of years at Hazleton and Center City before we both went different ways. And Marc was just telling us that he's now working with Wheelia Health, which you said is more of an acute care hospital, kind of
Uh,
short term.
critical care hospital. So, there's a little bit of government funding to make sure that we can survive against the big boys.
Okay, good. And you're doing family practice in Pine City and Hinckley,
Correct.
as
Yep.
well as addiction medicine. So,
Yep.
So today Marc's going to talk to us about the evidence-based addiction treatment for our evidence-based information about 12-step programs for treatment of addiction. And this is a topic I know that he's been interested in for quite a while, so I'm very happy to have him speak to this. So I think, Marc, we can go ahead and start.
All right. Well, thanks for the introduction. And sorry, I didn't recognize that it was Sheila because the window is so small. But hi, Sheila.
Hi.
Are you retiring soon?
No, well, I guess June 30th of next year, formally from the university.
Oh, okay.
I will continue with the to support the fellowship and
Yeah.
supervising teaching.
Okay. Well, that's going to be a huge loss, but it's a good thing you'll be still involved. And I haven't met the new program director, but nice to meet you.
Yeah, I'm David Peter. Hello, nice to meet you.
Hi.
And thanks for doing this talk. Sorry, I hope it wasn't too last minute we asked you to, but I the fellows have been looking forward to this.
Yeah, no problem. So just a little bit about myself. I started practicing in International Falls, Minnesota, which is my birthplace. And I practiced up there on the Canadian border for a couple of years, and then had my own issues with substance use disorder, and was out of medicine for a long time until from 2005 until 2011 when I started working with Pam, and then worked at Hazel and Betty Ford for a long time, and then went back to school and did some software development work, which I'm still kind of doing on the weekends, but went back to general family medicine again. And it's kind of interesting, the perspective that I have now compared to when I first started practicing. When I first started practicing, I mean, I did a lot of harm to people that had substance use disorders, and didn't mean to. I mean, I honestly didn't know that, the possibility of cross addiction, even like cross addiction between hydrocodone and oxycodone. Like we'd never been taught to that level of detail. So, now looking at it from a much different perspective, first of all, I don't do that anymore. And second of all, I realize just how many people have substance use disorders and how little time there is to really, get down to the nitty gritty of why they have high blood pressure, or why they keep falling, or why their liver enzymes are up. And it's not some weird idiopathic, hepatitis kind of thing. So anyway, but I have an interest, not only, of course, the medications that are used for treating substance use disorders, but also around 12-step recovery. So we'll get going. And come on. There we go. Sorry. I don't have anything to disclose. So why examine AA? Well, alcohol use disorder is very prevalent. The 30% came from the National Epidemiologic Survey on Alcohol and Related Conditions, the first wave from 2001 to 2002. But I think that's remained relatively stable over the last couple of decades. Of course, opioid use disorder gets a lot of airtime, which is understandable because it's been a pandemic, and the likelihood of rapid and young people dying is very high. Alcohol tends to kill people more on a decades-long basis, but alcohol is very prevalent, and especially in small towns like where I practice, um, there isn't necessarily as much access to illicit substances and not the access to any kind of formal treatment. So that's a reason why I'm interested in it. Between the last couple of decades, they've estimated that between 10 and 25% of those needing treatment for substance use disorders actually received them. It said 24% in the NESDA from 2022, which is better than it used to be, but still not great. And especially in rural communities, more people have used AA than other resources to address problems with alcohol. They're accessible, they're everywhere pretty much, especially in the Twin Cities. There aren't quite as many meetings here in central Minnesota, but they are available. They continue to grow, and they're inexpensive. You don't have to pay anything to go to a meeting. If you have a desire to stop drinking, you can donate a couple of bucks, but it's pretty inexpensive, and they are successful. So, AA does not keep formal membership lists. It's an anonymous organization, and there are quite a few within the fellowship that, hold pretty strongly to the anonymous aspect of it and get a little paranoid when there are too many questions asked about membership, et cetera. So these are estimates, but about 2 million active members worldwide and 120,000 groups in over 180 countries, and it's been translated into hundreds of languages. I even went to an AA meeting in Vietnam, and there were about 8 people there, mostly expats. But then I went to a AA meeting in Belize, and I was the only one there. But that was during spring break and on the beach, so I guess I can understand that. But I was there anyway. Interestingly, no study has shown that there's more of one demographic group than any other in AA. Now, of course, this is, demographics regionally. In central Minnesota, it would be mostly middle-aged white folks or Caucasian folks, but in different areas of the country, there's a true cross-section. It does seem, despite some of the rumors, that the strongest predictor of AA attendance is the severity of alcohol-related problems rather than those with fewer problems going to AA. And those that don't have much support at home or with other family and friends are more likely to attend AA for some type of support. Gender has not been found to be a predictor of AA membership. I don't know. I mean, most of the AA meetings I've gone to, it's been a predominance of males, but of course, men do have higher rates of substance use disorder, and men are more likely to binge drink. In 2020, 13% of adult men had alcohol use disorder, where it was 9% of adult women. Project Match, which we'll talk about a little bit later, showed no gender differences in rates or patterns either. In 1989, a committee of the IOM said, AA was one of the most widely used approaches to recovery, but it wasn't really very well studied. And most of the research, historically at least, has been done on males, on white or Caucasian males, and a lot through the VA medical system for, better or for worse. They've been a group that has high rates of use disorders, and in some ways they're easier to study, and in some ways not. I know Pam used to work through the VA system, and everyone I think has some exposure to the VA, so kind of know how that runs. But that's where a lot of the early on research has been done. This comes from actually a research book on AA Opportunities and Alternatives, published in 93. And there are kind of some paradoxes here. So, you know, a review of the early research will say things like it's mostly pre-experimental and it doesn't represent, you know, folks as they truly are. But it will all, you know, the early research also seemed to show that those treated, or at least treated professionally, who then attended AA were more likely to improve in drinking behavior and also more likely to be abstinent longer term. This was a meta-analysis done in published in 96, and again, the overall message was not very rigorous experimentally, and you know, quality was quite poor in most of the research that was done. But in better design studies, there were positive and quite positive relationships between AA attendance and improved psychosocial functioning beyond just abstinence or reduced days and amount of drinking alcohol. This is a large Cochrane review that was done in 2006. As many of you know, Cochrane is kind of the gold standard for meta-analyses. The Cochrane group will do a lot of research in compiling studies on whatever they happen to be looking at the time, and then combing through and deciding which are of, you know, good quality to include and which aren't. And you know, it's not, so each disease process is not necessarily published on every year, but they do try to, you know, go back and look at, for in this case, alcohol use disorder or substance use disorders every once in a while. This included 8 trials at about 3,400 people, and at their conclusion at that time in 2006, that AA was no better than anything else, basically. And some people went as far to say that we shouldn't recommend 12-step attendance to our patients, and others went as far to say that advising patients to attend 12-step recovery was actually malpractice, because there was no evidence to suggest it would improve outcomes. Good thing is that it didn't worsen outcomes, but you know, there wasn't strong evidence overall that it made much of a difference. But
Mark, excuse me, could you explain the difference between AA and 12-step facilitation?
yeah,
As you mentioned it there.
yeah, I'm getting to that, I think, in a
Okay,
couple of slides.
Great, thanks.
So we're talking about AA participation here. The studies were done on, and this Diana Chapman Walsh was a larger study within the Cochrane meta-analysis, and they had randomized folks into attending inpatient treatment formally, AA, or they had a choice of attending AA or outpatient treatment. And if you look more, so this is the outcome of just that New England Journal of Medicine article that was included in the Cochrane review. And these folks were EAP referred, so most of them had they all had some type of alcohol use disorder, but a lot of them were, you know, binge drinking too. And as you can see, hospital inpatient had almost double the outcomes of those going to AA meetings or those choosing whether to go to AA meetings or outpatient treatment. But if you look in more granular detail, what you find out is that those that went to hospital inpatient also went to AA. They actually went to AA at higher rates than those in the choice category. So, you know, that would suggest that, you know, adding on AA to hospital inpatient would indicate better outcomes because of AA attendance. So again, it's hard to study because there's also a lot of a tradition in AA. There's a singleness of purpose, trying to help staying sober and then also trying to help others. There's a bias that I know it works and I don't need to know why kind of thing. It's also hard to to do a randomized placebo-controlled trial on people attending AA. You know, folks will know whether or not they're in a meeting. Although I have been to AA meetings where it's not really clear whether you're in an AA meeting or not. But still, you can't randomize well and control those folks when you're doing these studies. And there tends to be cross-contamination. Again, folks that went to inpatient in the Walsh study also went to AA. So it was a contaminated sample, for better or for worse. And then it's hard to determine what are the aspects of AA that are critical. Is it just attendance, or is it working the steps, or getting a sponsor, or doing some type of service? Hard to know. And then the critics, on the other hand, say, you know, AA is a cult. Only the more healthy folks go to AA. And then, you know, we really only need to worry about perhaps harm reduction itself, and use only medications. So it can be, you know, that can be part of the difficulty to study, and for studies on AA to be taken seriously. So this is the difference, Pam, between AA and the 12-step facilitation therapy. AA, of course, is the mutual help organization that supports abstinence, that's been around since the mid-1930s, and, you know, has a couple million folks that belong, quote unquote, internationally. Whereas 12-step facilitation is a manualized, you know, formal treatment modality that tries to introduce patients that are getting treated for substance use disorders to the, you know, the kind of the different elements of 12-step recovery, the different language that's involved. And the purpose is to improve or increase attendance in AA long term, outside of the treatment itself. So that's the difference between AA and TSF, or 12-step facilitation therapy. TSF has goals of acceptance and surrender while in treatment. And there are a lot of elements to 12-step facilitation that have been, you know, studied separately, including motivational enhancement therapy, cognitive behavioral therapy. There's a spiritual aspect to it, not necessarily religion, but spiritual. And then there's a social aspect of, you know, the getting people involved in the fellowship of other recovering alcoholics. So we talked about how difficult AA is to study. You can't really do a randomized controlled, placebo-controlled trial that would give a firm outcome as to causation of the intervention of AA, that A causes B kind of thing. But we can look at, you know, these different elements of association, that in the end we can sort of say, well, clearly this is the causal factor that's leading to these outcomes. The first of all, and as you can see, this is from a textbook done by Dr. Kaskudis, who's a PhD in public health that is part of the alcohol research group out in California. She does a bunch of presenting around the country. So strength of association, dose response relationship, consistency, is it specific? Does it, you know, just doing one thing at one time lead to an outcome at a different time, or is it reversed? And then does it make sense with kind of just, you know, general knowledge or common sense? We'll look at strength of association first. So this is a study that was published in 1998 in the Journal of Studies of Alcoholism. And they looked at 3,000 male veterans, a year follow-up after receiving treatment. And they found that AA and NA attendance from months 9 through 12 was associated with more abstinence, freedom from problems related to substance use, freedom from the distress and psychiatric symptoms mostly related to substance use. And those folks, again, had more employment at 1 year follow-up when AA attendance was counted from months 9 through 12. So the 12-step attendance was more related to positive outcomes, then was just treatment attendance. And those that were participating in both did better, which is in alignment with what we saw in the Walsh study that was published in the New England Journal in 1991. So this is another meta-analysis of folks, and it is a 8-year follow-up of 466 individuals that were problem drinkers who had contacted an alcohol information line and or referred to a detox center. And they looked at folks whether they had then attended formal treatment alone or formal treatment along with AA attendance. And you can see double the abstinence basically at 1 year follow-up and at 3 years follow-up for those that went to treatment and AA. And it did reach statistical significance. That was published in 2000. So there is a strength of association that, and it seems to last as well between 1 and 3 years after early on AA attendance. Is there a dose response relationship? In other words, is 2 better than 1? If 1 works well, let's try 2 kind of thing. And there were a bunch of studies looking at this. I won't go into great detail, but it was clear that higher meeting attendance during and after treatment, kind of the minimum being about 3 meetings per week, was associated with greatly more abstinence and reduced problem drinking long term. As far as abstinence went, Kaskoudas looked in a article in 2007, and those that had received some type of treatment and then followed up to 2 years, those that had not been attending AA in 6 months prior to the 2-year point, only 30% were abstinent. If they went less than weekly, 40% were abstinent. And those that went at least weekly had 75% abstinence. Keeping in mind that these are reported outcomes, they did not do urinalyses or urine drug screens on these folks. That's also one of the difficulties of studying Alcoholics Anonymous. This was another study. It was 473 individuals with alcohol use disorders that had gone to some type of treatment, and they looked at whether or not AA meetings during year 1 affected outcomes at year 1, and if that lasted into year 8 long term. As you can see, no AA was about 21%. At year 8, no AA, 35%. As you go up to 2 to 4 meetings a week and up to 5+ meetings a week, basically double or triple the outcomes, both at year 1 and year 8. Keeping in mind that this is only studying AA meetings during year 1. So we don't know what the people were doing at year 8, whether or not they continued to attend AA or not. Likely they did, but all we know is that when you go to AA early on, you're more likely to stay abstinent longer term, up to year 8 in this study. And the outcomes were positively related to remission from alcohol, of course, abstinence. There were lower levels of depression and higher quality relationships. And, Humphrey and Moose and Cohen, Moose and Moose are a couple that have done a bunch of studies. In this journal, Studies of Alcoholism article in 1997, they said that, AA probably helps more people than any other type of treatment, at least in that sample. So there's a frequency of AA attendance that has a dose-response relationship to drinking outcomes, and it seems to be minimum of 3 a week, although we can see that weekly attendance also has higher outcomes than even no attendance. Is there consistency between trials? Well, I think we've seen quite a few trials showing that. This is a meta-analysis of a bunch of VA inpatients and that were problem drinkers, but also some of them had moderate or severe alcohol use disorders, what we would call them now. And they looked at years 1, 3, and 8, at those that had not been getting any exposure to treatment or AA. They looked at outpatient only, those that went to AA only, and then that went to both treatment and AA. And we can see a consistent relationship between AA involvement and better outcomes. Are the results temporarily correct and specific? Do we have a person A who has an alcohol use disorder? We apply AA to them and they have better abstinence rates at a point down the road, or do people not necessarily get sober after attending AA, but maybe they had attended AA previously in their lives and now they're incorporating it into their daily activities. We need to make sure that it's not a past exposure to something that is affecting outcomes now, rather than it is a current exposure to something, in this case, meetings. Project Match, that's probably all have heard of this. It was sponsored by NIAAA starting in 1989, cost $27 million. I think it's the largest psychosocial research project probably that's ever been done, certainly the most expensive. And Project Match was done to try to figure out, they were trying to match personalities to treatment types for outcomes of alcoholism. Could we determine, is there alcoholic personality, and of those personalities, which type would do better in which type of treatment? And they randomized to 12-step facilitation, which was trying to lead to AA, cognitive behavioral therapy, and then motivational enhancement therapy. I think we're probably all familiar with what all of that means. Motivational enhancement therapy, of course, is motivational interviewing at its base. 952 patients, 5 sites. They also had 774 aftercare patients at 5 sites that had gone to IOP or some type of residential treatment. And again, CBT, MET, or TSF. I put this on here because it's amazing the follow-up they had on folks longer term for the participants in Project Match. At 3 months, 6 months, 12 months, it was in the mid to high 90s of folks that were not lost to follow-up. That went out for 10 years, and it was still around 85% of those that were not lost to follow-up after participating in this trial, which I thought was amazing that there were those high levels. It adds credence to it, I guess. Match did show that there was a association between the frequency of meeting attendance and involvement in months 1 through 6 into alcohol abstinence during months 7 through 12 in the outpatient group. But there seemed to be no differences between the 3 interventions in the aftercare arm. Those that went to some type of treatment and then, had AA or 12-step facilitation, CBT or MET, they all had about the same outcome, and all treatments were of high quality. So that probably is part of the reason why outcomes were so good. So you can see it 1-year follow-up, 3-year follow-up. There really wasn't much difference between the 3 different types of interventions. However, people have stretched and peered between the lines on all of the research or outcomes and the numbers that have been compiled from Project Match to try to determine, can we figure out more than just there was, no intervention was better than another type of thing. And so McKellar and the rest in Journal of Consults Clinical Psychology in 2003 looked at the 2,319 male VA patients, and it was looking at whether or not, folks that had high motivation, really high psychopathology or high anger issues had better outcomes in different types of treatment. Interestingly, for AA itself, they found that there was a negative relationship between motivation to recover and AA involvement at 1 year, and that those folks that were more motivated had more alcohol problems at 2 years. Those that had higher psychopathology, you know, there was really no difference between AA involvement and no difference in alcohol problems at 1 to 2 years, indicating that, you know, those that are less motivated can do very, very well in AA, probably do better. And those with higher psychopathology also do as well as those with lower psychopathology, whatever that means. So it's not indeed just that those that go to AA are more motivated or more healthy. Interestingly, those who had social systems that were non-supportive, TSF did better, especially for those that had family relationships that were supportive of continued problem drinking, did better in AA. Angry clients seem to do better with motivational enhancement therapy. I think probably because that's, you know, the basis of that is not preaching to patients, but trying to have them realize on their own their need to change behavior and come up with their own plan. And it seemed that those that have really high dependence on alcohol did better in AA or TSF rather than CBT. Does it make sense with what we know about the world? Why does AA work? What are the mediators that support positive outcomes? Does it make sense? Well, there's self-efficacy involved. You know, AA has some to do with improving people's confidence to reduce or stop their drinking. And again, we talked about how participation, when you looked at Project Match, AA participation itself did improve percentage of days abstinence in later on in a 12-month period. And so, you know, there is that self-efficacy that I can go to AA or I can be involved in something that is supportive and it will make a change in my life. There's not that kind of feeling of hopelessness. That was also shown at 3 years follow-up. There's, you know, increased social support, better friendship networks, and better coping responses when there's kind of herd recovery involved. And those that were involved and active in AA had more abstinence at 3 years following a treatment episode in this Bond and Cascudis article in 2003. And it did seem that the elements of AA in this case, working the steps, were more of what had contributed to positive outcomes. People had better coping efforts, learned to live life differently. So, you know, the other thing we look at is, or that is discussed is it just AA attendance, number of meetings attended, or is it involvement, granular involvement in AA, the fellowship and program itself that leads to better outcomes? And overall, looking at the research, just going to 12-step meetings isn't probably as helpful as becoming actively involved in the community itself, although most studies have just looked at meeting attendance. And if you are thinking or believing that the involvement in AA itself is what is the secret to the secret sauce involved, there was the strongest evidence for those that had a sponsor and were more involved now than AA in the past. Those seem to do better. Those are the folks that seem to do better. The next strongest evidence was for doing 12-step work or leading an AA meeting. And the weakest or weaker relationships were those that had been sponsoring others, worked the last 7 steps, and those that worked only the 13th step did horribly. I don't know if any of you know what the 13th step is. It's basically going to an AA meeting to try to hook up. Not an interest in getting better, but finding someone that's just as sick or sicker than you are. Now, there was a repeat Cochrane review done in 2020, thank goodness. I think all of us that at least have some involvement in AA professionally and or personally were waiting for this one to come out. It was again a meta-analysis, large meta-analysis of 25 different studies that had over 10,000 research subjects. And you know, they looked at these folks over all of these different articles over a certain amount of time, trying to determine whether or not, you know, just like the first one showed that really there was no evidence that AA does better than anything else. Well, they found this time that those that had manualized AA or TSF involvement compared to things like CBT or MET had much better outcomes at 12 months. So the risk ratio was 1.21 with the confidence interval being met for statistical significance. And interestingly, that effect remained consistent at 2 years and 3 years. And that overall, 42% of participants, those participating in AA, would be completely abstinent a year later compared to 35% receiving other treatments. Again, that doesn't seem like a lot, but if we're talking about a, you know, treatment for hypertension or for, you know, cardiac events, stroke, the difference between 35% and 42% is amazing. So I think we need not lose sight on that. And it did seem to be that fostering of increased participation in AA beyond the end of whatever facilitation was going on in treatment. So concluding, about 2 times higher abstinence rates in those that attend AA. There is a dose-response relationship, higher attendance, higher abstinence. Seems to be a minimum of 3 meetings a week, at least in the first year. Multiple studies have shown consistency that that's true in different situations, in that, you know, if you have attended AA in the past, it doesn't mean as much as if you're attending AA now. So, you know, getting the dose of the treatment now, if you have an alcohol use disorder, is the element that leads to success. Specificity is really hard to determine, but like I said, when you goof around with the numbers, you know, more angry patients do better with MET and some others do better with CBT. But the thing about AA is that there are elements of CBT and MET that are intrinsic in working 12-step recovery and in, you know, trying to change one's actions through, or change one's thoughts through different actions, and trying to, you know, learn to believe different truths about oneself. And then it seems to make sense with current theories of behavior change, you know, that folks that are involved in a community do much better. I had worked with a neurologist out at Harvard for a little bit that had been doing research in India on those that were using intravenous heroin. And if you think there's a bias against intravenous heroin users in the US, try going to India. They were really outcasts of society. And in his research, it wasn't about remaining abstinence. It was about whether or not IV heroin users did better in communities or better on their own. And those that were involved in communities together, all using heroin IV, had twice the rates of remaining alive, I guess for better lack of a better term, at 1 and 3 years. So just the social involvement itself seems to make a difference in many elements, and that makes sense for AA as well. There's a bunch of practice guidelines on AA participation, blah, blah, blah. This is the summary we just talked about. You can look more closely at that again if you want. And I do like ending with this slide because I think it's okay to not discount an element of not a miracle happening, but some mystery as to why involvement in communities and in 12-step communities and fellowships such as AA lead to better outcomes. It isn't all probably based on certain receptors in the brain and trying to parse out, that type of change going on. There's some type of spiritual difference in experiencing life that happens with those that are involved in 12-step communities compared to those that aren't necessarily. So I hope I didn't go over. No, I think we're okay.
Mark,
That's it.
do you mind commenting upon studies comparing like 12-step versus things like smart recovery?
I'm sorry, could you repeat the question? Sorry.
Are you aware of like some research, if you could summarize it, on like 12-step AA type programs versus programs like smart recovery in terms of peer support?
I've never found good research that's convinced me of either way. If you know of any, please bring it up or send it to Pam or something, because I do get asked that question not infrequently, and I don't have the answer for folks. Are you aware of something that I'm not? Because if you are, tell me.
I'm not, that's why I'm asking.
No.
Yeah.
Yeah.
Oh, I'm not either.
Yeah, certainly not direct comparison. Within the same study, I don't think there's that.
No.
Yeah, and smart
Um,
recovery is more CBT.
yeah,
I'd love to see like a comparison of contingency management, AA, and like smarts to see if it's the connection and coming as often versus specific more modalities versus would be nice to see, but
Yeah.
it'd be hard to design.
hmm
It's
And
that
hard to pull
right?
off.
Yeah.
You mentioned that a lot of the earlier studies, particularly, just were in men. We know now that, while men still may have higher rates, that's changing. I mean, the gap is getting smaller and smaller between the genders. And so I wondered if any of these studies, separated out genders and looked at whether outcomes were different for men and women, or other things that, other treatment modalities.
Certainly
No.
none of the research that I looked at for, presenting or for this presentation, but
Mhm.
there have got to be some out there. Again, it's really hard to find quality studies that aren't just, sort of naturalistic studies that ask, kind of variable questions with little follow-up.
Yeah. In that most recent Cochrane review by Humphrey, were there men and women both in those studies? Do you know?
Oh yeah.
Uh-huh.
Yep.
Yeah, but they were not separated out. They were just all together. Yeah.
Right. In the meta-analysis, at least, yeah.
Yep. Okay. I think that a lot of people in AA would say that it's efficacious and that they have found, I think that social support, that identification with other people, that maybe reduces shame and stigma to some extent. And also that idea that the more involved you are, the more benefit you're going to get from it. So, that's anecdotal, I know. I'm just saying that, people who have seen that, I mean, and certainly, true for myself that, the benefits of AA persisted beyond treatment, beyond um, other modalities that I tried, and to get sober myself. So, but yeah, it's good to see some data and that people are trying to look at it more objectively. I think,
And I do think there's less rigidity around, completely separating out medications that can be used for treating substance use disorders and, 12-step involvement. Historically, that's kind of been poo-pooed, at least, through the
yeah,
rumor mill. I think that folks are doing a better job probably of not bringing it up into a bigger group when it doesn't apply to others. And I think there is less, I guess, less discussion and a little bit less bias around taking medications for not only substance use, but other mental health conditions.
right. That used to be a,
Mhm.
like you said, sort of a no-no or looked down on in AA, but I think that's changed a lot. I think the other thing, I mean, for the fellows and all, is that AA meetings do vary. I mean,
Hmm.
as you kind of alluded to, I mean, some are more strict in terms of working the steps and having a sponsor. Some are more encouraging of that. Others are more social kind of. And so, I mean, one thing I always tell patients is, if you're, encouraging them to go to AA, I always tell them to try different meetings. If you go to one and you don't feel comfortable or you don't feel like you're a fit there, try a different one, because there are definitely differences between meetings. And there are also, of course, men only, women only, um,
Atheist only,
LGBTQ. What's that?
atheist only.
Yeah,
No.
LGBTQ friendly, so yeah, all kinds of meetings. And then of course there's all kinds of other substance anonymous. So like cocaine anonymous, opioid anonymous, or narcotics anonymous, So that's the other thing that's important to know, which basically apply the same 12 steps, the same social supports, um, but are more friendly to people using some of these other substances. So I think that's an important piece as well, that, to let patients know about if they feel uncomfortable. Although, more and more, like we said, I think AA is changing too, and it's not necessarily, that they look down on addicts and stuff as much as maybe at one time they did. So,
It's also interesting that the different flavors between different 12-step groups or fellowships, that when a group of individuals get together and get sober off of a drug or a substance, they don't necessarily stop all of the behaviors that made them, kind of similar to each other, uh, uh, as far as personalities, when they get clean and sober. There's a little bit different flavor between cocaine users and opioid users and alcoholics, and it's it's kind of refreshing, actually. It's fun.
mhm. I think one of the other interesting uh, parts of AA is that it does kind of cross all demographics, career positions, socioeconomic class outside of the meeting. That just most of the time isn't even discussed. And, people don't even talk about that. So, um, they're pretty accepting of anyone, from people who just walk in off the street to
Mm.
to whatever doctors who attend. So there's a question in the chat. I want to share. Mary is asking, are there any data on virtually delivered AA? I feel this is an option that came about with the pandemic and people needing to still meet. So, I think that's true. There were many groups that shifted to virtual groups, and I think a lot of that there has persisted to be more virtual groups than there used to be. Is there any data about that? Do you know, Mark?
I haven't found any data on that, although that's really fascinating.
Yeah.
I hadn't thought much about that. I've heard anecdotes about outcomes and participation and, other social outcomes of virtual attendance versus personal, but I've not seen any study that's been done as of yet. Maybe it's too early.
Yeah, I'm just
Yeah.
kind of curious because I figured like that might help with the dose issue. Like if people have a hard time it being, if like going to at least 3 meetings a week, it might be a barrier to try to make those. But if you can join from your home while
Yeah.
your
Mhm.
kids are doing their homework or whatever, it might be easier. But then so you can increase the dose, but then you might miss out on some of that social support friendship network that I feel might be easier in an in-person setting.
Yeah, and
Yeah.
is it is the dose 3 inpatient or in face-to-face meetings a week or 4 virtual meetings a week,
Yeah.
What's the effective dose? Be interesting to hear or see.
I think there is some data about virtual treatment, right? Which is I don't know, Sheila or David, do you know?
AOP
Yeah.
virtual versus,
So, I can tell you from the CBT perspective, for
Yeah.
addiction, that it's, this is effective. The tele delivery system is, quite effective with CBT specifically. I don't know that I can answer
is
that.
that individual or group we're talking about?
Individual.
That's a little different animal though, I would
Yeah.
say, yeah. That's a
Yeah.
individual, kind of therapy being delivered.
Mhm.
Have you seen the evidence on like IOP type groups?
Oh, for tele?
Yeah, tele IOP versus in-person IOP. I'm interested if there's been any published data yet on that. It's not still the same. It's still kind of, you're in a formatted in delivery, but
Mhm.
still it's more group. Be curious.
From what I recall, I mean, it's effective.
Yeah.
I can't cite a specific.
Yeah, me neither, but it seems
Yeah.
like there has been
Oh.
some work on that.
It's definitely, I'd love to see when this data comes out. I'm sure someone's going to do it. It'd be fascinating to see. Especially in an area where someone feels like their meeting doesn't fit them or, it'd be nice to have it all, larger network.
Right.
Right. Well, that's I think it's really interesting, Mark. And it's important for us as addiction providers to know this information, to be able to share with patients, to be able to base our recommendations on some data, even if it's not ideal data.
Yeah.
At least it's something, and I think that's important. And a piece I think that sometimes, addiction providers maybe forget to emphasize. So, any other questions for Mark? Really appreciate you sharing this information.
Yeah, Mark, actually, I wanted to ask Mark if you are open to it. Would you want to do this talk for our fellows?
Oh, sure. Yeah,
Because
Aren't they?
we always come up about discussions, or even for the journal club each year, or something like that. Either way,
Yeah.
I think this topic comes up all the time, and it's hard to get someone to speak on it. Really go into the evidence and not bringing in too much of their own personal bias. And I appreciate you doing that.
Or residents. So we have
Yeah.
now a more robust
Yeah.
didactic series for our psychiatry residents.
Yeah, you just let me know when and where. I'll be there.
Okay.
Great. Thank you so much.
Yeah, you're welcome.
Thanks a lot.
Thank you. Have a good
My
day.
end, sorry, Mark, I have one other question. If I do have a patient that is interested in AA, what's the easiest way to like see what a list or what meetings are available?
Google.
If it's in the Twin Cities, yeah, the intergroup website
Sure.
seems to be the best, yeah.
All right.
Right, there's a St. Paul intergroup and a Minneapolis intergroup. So depending on where they want to go.
There's a meeting finder app too, I think.
Yeah, I think if you just go to AA,
Yeah.
you know, .org, there's a meeting location finder.
Yep,
Great.
aaintergroup.org.
Mhm. Okay. Yeah, so.
Yeah,
That's
you do
good.
have to be careful because there are some sites that are, you know, clickbait.
Oh,
They get you on there and then want you to, you know, come to promises.
Yeah, okay.
Thank you.
thank you.
Thank you. Thanks, everyone.